for being here this morning. One of the things
Okay,
that,
let me go ahead and get
go ahead, it's all up to you.
Thomas.
Thank you.
How about I just get started? And you want to thank Marla for having me be here today. I'm going to share my screen here just a second so everybody can see. I got some PowerPoint slides, and the main reason why I have them is just to keep me on topic. And I changed the topic a little bit to talk about um, dental care and long-term care facilities, even though we all know that there's a lot of patients with intellectual and developmental disabilities who spend a lot of their time in long-term care facilities. Um, Let me tell you a little bit about myself first. I've been at Ohio State for almost 5 years. Previous to that, I've spent 22 years on faculty of medical schools and children's hospitals. During that time, I've focused on providing care for patients who have complex medical issues and dealing with populations that are truly underserved. And our individuals who live in long-term care facilities are truly underserved. Their dental need often becomes excessive and often is untreated. And I just wanted to thank you guys for allowing me to speak. Marla and I have worked together for a long, long time, and since I came here to Ohio, and we've been able to do some wonderful things. And seeing that she's on the call makes me feel like you guys are doing great things as well. So I have a few topics that I have a few slides, and the main reason why I have the slides is to try to keep me on topic. I'm more than willing to answer any questions. Marla, I'm going to make you the person if you could follow the chat and chime in if there's any questions, or just chime in if anybody wants to ask me a question. I want this to be pretty casual because um, I hear this group gets things done, and if I could be of any resource to you, I would like to be. First of all, whenever you work at Ohio State, we need to do our land acknowledgement. And I just want to, first part of my career, I was a commissioned officer in the U.S. Public Health Service, and I was stationed on a Native American reservation in Eastern Oregon. And it truly set me on my career because my first mentor was an internal medicine physician who saw in me um, the ability to both navigate healthcare. I consider myself more of a healthcare provider than I am a dentist, just because what I do is pretty unique for what dental providers do. Currently, I'm the dental program director of the Nisonger Center, and the Nisonger Center is a university center of excellence for the developmental disabilities, and I'm the dental program director. And we take care of individuals with moderate to severe intellectual and developmental disabilities. And we train a lot of providers, and we're trying to train community providers to help take care of this population. Unlike most dentists, we do take Medicaid. And as a Medicaid provider, I see the added um, overburden of dental disease in this population. Currently, we have about 300 patients on our waiting list trying to get in. We were fortunate to bring on another provider, but we're trying to weed that down a little bit. Little disclaimers. This is where I receive funding, and I want to thank the Franklin County Board of Developmental Disabilities and the Delta Dental Foundation of Michigan, Indiana, Ohio, and North Carolina for giving us significant funding to keep our doors open. If anybody has any ins on any hair growth products, please send them my way. I could always use a little added revenue since I work at the university. So what's our learning objectives? One is, why is oral health important? One of the things that I'd like to stress is that oral health has never been, ever since the Medicare Act of 1964, dentistry has always been excluded from a lot of our programs. I mean, we have Medicaid program that it was included in, but dentistry has always tried to stay out of the Medicare realm, unlike in medicine. I think that significantly impacted the oral health of our population, and unfortunately, probably to the for the worst. Um, we're going to talk a little bit about aging and oral health, and a lot of this goes for intellectual and developmental disabilities as well. And we're going to talk a little bit about role of the healthcare providers and long-term care facilities to facilitate oral health. So why is it important? There's hundreds of studies, but I just pulled out a few that I thought were pretty pertinent to this group. One is it impacts their physical, psychological, and social well-being. Um, everybody loves to take a look in the mirror. We all know that if a patient has poor dental health, there can have a severe economic impact on their overall health and economic well-being and quality of life. You don't see, you always question whether or not it's a very good restaurant if you see a waitress with terrible teeth. Um, it does have a significant effect, and it doesn't matter how old you are or if you have an intellectual developmental disability. Each of us takes a look at her in the mirror. Each of us wants to see her smile, and not being able to smile or it can have a significant social effect on their social well-being. We all know that periodontal disease it causes an increase in plaque formation in atherosclerotic vascular disease. That's very well documented now. There's many studies that have shown that. We know that um, periodontal disease is associated with diabetes. And the question we ask is it because of periodontal disease they have diabetes, or is it because diabetes they get periodontal disease? It's like the chicken and the egg question. One of the answers that I mean, when people start losing teeth, their diet totally changes. So all of a sudden they have a diet that's high in carbohydrates, high in refined sugars, and that exacerbates the diabetes. We also know that there's could be a significant correlation between dementia and impairment with oral health. It's just like I have no idea why the U.S. separated the mouth from the rest of the healthcare system. I kind of wish we were more like Spain, in which all the oral health providers do their 4 years of medical school and the dental school as a residency afterwards. It would integrate oral health more into the system and have a better impact, I believe. Um, and one of the things that I really work with here that I deal with on a daily basis is the significant increased risk of aspiration pneumonia. A lot of times when I take care of patients, the main reason why I see them, if they have feeding tubes or is to significantly decrease the risk of being hospitalized for aspiration pneumonia. Our main goal is to remove a lot of the tartar and calculus and relieve some of the bioburden to decrease the risk of aspiration pneumonia. It's pretty funny. Often we have patients that come in that haven't been here for 4 or 5 years, and you ask them how many times they've been hospitalized with pneumonia. And often it's been multiple times per year. Then we get them on a 3 or 4 month recall, and we go years without having any type of hospitalization due to pneumonia. And that's the same thing that you face in long-term care facilities. Improving the oral health and oral hygiene of the patient while they're in your facilities will significantly improve their overall health and decrease the risk of aspiration pneumonia. I mean, we're doing a study now, and we'll talk a little bit about that in a minute, but we're seeing there's some tools that we can probably pass on to the long-term care facilities that could significantly improve the oral hygiene of our clients that we serve. And the other thing that we have to deal with is more people have teeth as they age than in the past. I mean, if you look in the 1970s and 1980s, most of the people who were in long-term care facilities were edentulous. Nowadays, vast majority of our population can have their natural teeth well into until death. My dad just passed away at 94, and he had every tooth in his head, unlike my grandparents who were edentulous. What does that correlate to? Probably it was the inclusion of fluoride in the community water systems starting in the 1950s. We see because of that, people are able to retain their teeth. And unfortunately, fluoridation is currently under attack. And we're starting to see some early results of communities who stopped fluoridation 3 to 5 years ago, seeing a significant increase in the amount of dental disease and caries in both the elderly and in children. A good example was a study that was just done in Naples, Florida. So I went through the CMS regulations, and I am telling you guys, I'm glad I don't have your job. Because when I trying to find the dental key elements of oral health in the CMS regulations was like trying to find my lost hearing aid on the golf course. Um, it's that booklet is about 900 pages long, and there is 5 pages on oral health. And here are what the CMS regulations say for oral health. One is failed to provide or obtain outside resources for routine and emergency dental services. For you who are on this call, this sometimes is exceedingly difficult due to the fact that the vast majority of general dentists do not take Medicaid. I think the current rate is around 11%. 11% of general dentists take Medicaid. If you have a child, the pediatric dentist, it's up to 85%. Oral maxillofacial surgeons are more likely to take Medicaid as well. They're around 50%. But it's often very, very difficult for especially individuals in the rural parts of the state, or if you don't have a FQHC that's fairly close to be able to see this patient population. And a lot of times our patients are often so medically complex that a lot of the community dentists and community providers don't feel competent in order to take care of them. You should see the faces of residents when we're taking care of a patient who's on a ventilator. I mean, it's something that's out of their comfort zone, and if it's out of their comfort zone, they tend not to want to do it. I have a colleague at UCLA. He says that we practice at the intersection of medicine and dentistry, and that's basically what we do. I just had somebody come in 2 days ago. They brought him in from a facility, a group home, and they were adamant that there's something wrong because he's not eating, he's not eating, he's not eating. And I look at his mouth looks great. And I asked the question, when's the last time he went to the bathroom? Sure enough, it was nothing to do with his teeth, but he had a bowel obstruction. So we went ahead and referred them to where they needed to go, and now it's been taken care of. Did not assist the resident make appointments for dental services or provide transportation. And this one's a good one. I mean, did not promptly within 3 business days make a referral for a patient with a lost or damaged partial or full denture. That's good luck on that one, ladies and gentlemen. That one, trying to find, I mean, you can make the referral and have them come in, but it can be quite difficult to find a dental provider sometimes in that circumstance. And the other ones are failed to get them Medicaid and charge them for services that's covered by the state plan and or replacing a full, partial, or denture if it's and let's face it, how often have you gone in and found, I've seen this numerous times, couple of individuals, one has a denture, one doesn't, then you come by a week later and the one that didn't have the denture has the other one's denture in their mouth. We've all seen it, especially in Alzheimer's units in which patients or clients walk around and will insert other individuals' dentures in their mouths. So why does aging affect oral health? And the main one is the decrease in dexterity. A lot of the individuals no longer have the ability to use a manual toothbrush. So what can we do to help that? One is we can start utilizing some of the technology that's out there that help individuals with intellectual and developmental disabilities do better oral hygiene. There's a few toothbrushes that are, if let's say a stroke person has lost the ability to use their right hand, there's a couple of toothbrushes out there that doesn't take any type of effort. All they need to be able to do is hold the toothbrush, and the brush will actually brush their teeth. Some of our electric toothbrushes like Sonicare and Oral-B, they're not meant to brush. You're meant to hold it in place and move it from one spot to the next. So individuals who've lost some of their dexterity or have had a stroke can very easily use some of the new electric and electronic toothbrushes to improve their oral hygiene. One thing is a decreased salivary flow, and this is a big deal for the elderly population. Just naturally, our salivary glands start producing less saliva. And over a period of time, everybody who, as they age, will start getting dry mouth. And when individuals get dry mouth, what do? They start drinking sugar, beverages with refined sugar in it, because the refined sugar will coat the dry tissues of the mouth and actually give them comfort. So what does that do? It just significantly increases their dental caries. A lot of the medications we take as we age, blood pressure medication, some of our Alzheimer's medications, patients like if they have a ventilator or if they have any type of aspiration risk, often they're on medications to decrease salivary flow. And it can cause extreme dry mouth, and dry mouth is a major issue. And we see it often, like in Down syndrome. When I first started taking care of patients with Down syndrome, it was a miracle if you had somebody over 35. Now we have patients who are in their 70s who have Down syndrome, and we all know that individuals with Down syndrome, usually by the time they're in their 50s, all have significant signs of Alzheimer's disease, and they all tend to have dry mouth. One thing I have to say, I've worked in medical schools and public health in 8 states. The healthcare system here in Ohio is significantly better than those states in which the patients with intellectual and developmental disabilities have significantly better health outcomes than the other states I've worked in. I remember when I was at UAMS and in Arkansas Children's Hospital, I remember seeing one patient in their 70s. Here in Ohio, I see patients in their 70s and 80s every day. Um, Other things that happen is there's changes in dental morphology. And the main thing that happens is the dental pulp of teeth tend to resorb significantly as patients age, especially when you get to their 70s and 80s. So a lot of times we'll see patients with significant root caries and they actually have no pain and there's no dental infections due to the fact that the pulp has receded so far that the tooth doesn't become abscessed. And there's many times where we'll make the decision if a tooth breaks off on an elderly patient, if it's the pulp is receded and we'll leave the tooth there to prevent significant bone loss because bone loss occurs when a tooth is extracted and it can improve the quality of life of the patient. So what can we do? One is we use, like I said earlier, we can utilize some technological advances to improve oral hygiene, self-care. I mean, it's something, I mean, I know a lot of our patients may have guardianship trusts. And when you do have a guardianship trust, a good thing to purchase would be one of these high-tech toothbrushes. They can run anywhere between $200 to $400. And they can make a significant impact on the bioburden and plaque that's in our elderly patients and our patients in group homes and facilities. The other thing is we need to train our staff how to provide oral hygiene services. And teaching someone how to brush somebody's teeth is something that's not as easy as you would think. Doing it correctly and safely is often quite difficult. We spend a lot of times with our caregivers teaching them how to how to brush their clients' teeth. And often we have them demonstrate first and they come from the front and the patient's head's not stabilized. So often our patients hate getting their teeth brushed because it becomes exceedingly painful because their head's not stable in space, and when the caregiver is brushing their teeth, they can traumatize the soft palate. So one thing that we've done, we have a study here that we're using soft tissue retractors in which we're teaching individuals how to brush teeth. And another thing, if we have patients who are very combative and non-compliant, often caregivers don't want to brush their teeth because they're afraid of getting hurt or injured themselves. So we have a study here we're doing now that's teaching how to use a soft tissue retractor and the proper techniques to brush their teeth. And we're seeing significant improvement in that group compared to the norm group that's just was learning how to brush their teeth using the correct technique. One thing I want you to do is if you have tooth really are not that great in cleaning individuals' teeth. They're great at cleaning patients who have edentulous mouths, and they're great sometimes for putting salivary substitutes in patients' mouths to help moisten the tissue. But as a usual practice with anybody with teeth, please recommend using a toothbrush. And often using a fluoridated toothpaste is great, but if a patient has an aspiration or swallowing risk, it would be better just to dip the toothbrush in mouthwash that has an antibacterial component. Start using fluoride. I mean, you as physicians can put fluoride varnish on our patients. Fluoride varnish is something that's very quick and easy to do. I think the average fluoride varnish, the cost is maybe $1.50 for the application, and I think it's you can get reimbursed from Medicaid. I think it's $35, and you can teach your nursing staff to put fluoride varnish on our patients who have some root caries. If you could have oral health provider, if somebody could use something like silver diamine fluoride, which is it turns your teeth black, but it will it'll arrest dental caries and root caries. And you're often have to make decisions on what's best. My mother-in-law, she was in a long-term care facility and she started getting significant root caries, and it was too risky to go ahead and extract her teeth because her lung function was so poor. So I made the decision to go in and just use silver diamine fluoride just to let her to arrest the caries and don't do any treatment. And she passed away without having any type of issues with any dental care or dental pain. And that's something that you might want to think about incorporating in some of the long-term care facilities. Start prescribing some salivary substitutes for those with dry mouth. I would look at the two that are most common, the two ingredients that work the best are glycerin and carboxymethylcellulose. And actually, I prefer carboxymethylcellulose because it actually coats the tissue. I mean, glycerin coats it too, but it coats the tissue pretty significantly, and it gives the patient the same sensation if they drank a sugared beverage. And it doesn't cause caries, and patients tolerate it usually pretty well. Usually carboxymethylcellulose is by prescription. Glycerin products aren't. And there's Aqua Oral, Biotin. There's a lot of them out there, and often some are flavored, some are not. And you may want to see what the individual tolerates the best. And if you can try to find somebody who does mobile dentistry. Transportation for our patient population, both with intellectual and developmental disabilities and in nursing homes, is often difficult. I mean, we have patients that are brought in by ambulance because of being on ventilators and unable to sit in wheelchairs. Can be difficult. It's costly. If we're able to find a lot of there's mobile dentistry companies. I think there's a few in Ohio, and if we can utilize them to help improve the oral health of our clients, it can make it so much easier for them in the long run, and have them keep their teeth through their lifetime. I mean, there's been a lot of research now on, and there's a lot of studies now on hospice dentistry and what we should do and what we shouldn't do. And a lot of these studies are looking at just doing whatever we can to keep the patient comfortable and treat the symptoms, but not necessarily give them the cure. And one of the things that I always like to do, I like to end this slide. This is when I was at the University of New Mexico. Is often when we take care of our patient population, 99% of the time you feel like Superman because you're able to do things with patients and that nobody else wants to do or can do. You're giving them services and you're providing them with resources and care that otherwise they wouldn't receive. But that 1% you want to jump off the cliff. Um, we Everybody has those days. When you work with the difficult populations we work with, I think everybody needs eventually, sometimes, to get a pat on the back. Uh, and by the way, if any of you guys want a dentist, I'm not your dentist because I take care of patients who have medically complex, and I want them to have their best life possible. If that means trying to if that means taking out a bunch of teeth and keeping them edentulous so that way they could have the best quality of life, that's what we do. I'm not going to be doing veneers on you guys, so I'm opening up the floor to any questions. My goal is to talk for 35 minutes, and I'm right at 35 minutes. Any questions? Here's my contact information. And if you need any questions, please email me. And I'll try to get back to you as soon as I can. We at the Nisonger Center, we take care of patients at the university, but in reality, since we're at Ohio State, our patients really is everyone in the entire state.
That was one
Any
of my
questions?
questions. That was a question. Do you take patients from all over the state? And she said you just answered that. Um, but I did have a question. So we see patients with TBIs in long-term care as well, and
Oh, yes.
they're cognitively impaired, and often cognitively and as a result physically impaired as well. Do you see those kind of patients as at your clinic?
We do. At first, I mean, the Nisonger Center usually, at first, we were taking care of patients that um, usually the disability usually had occurred before the age of 21. But lately, I mean, our patients are all by referral only. They really are. With the exception of some of the patients in Franklin County. And we get them referred by the Franklin County Board of Developmental Disabilities. Um, but yeah, we take care of patients for traumatic brain injury all the time. I had a patient that was just in 2 days ago that had a mountain bike accident, and he's on a ventilator, and we take care of him. The other thing that we have in our facility, we have patient lifts, we have vac packs, we have things that we can use to help stabilize the patient. Because the last thing we want to do is take care of our individual in a wheelchair. Because if we have a medical emergency, we want to be able to treat that medical emergency. Treating a medical emergency in a wheelchair is quite difficult. Yeah, I do a physical assessment on the patient in the waiting area to see if they're even if they're physically able to tolerate dental care. And I have to thank my internal medicine mentor at first. When I first joined the U.S. Public Health Service, he said to me, Steve, you're not seeing a patient until I tell you. In the first month of my career, all I did was histories and physicals on patients because he wanted to make sure that I could identify those patients that would have difficulty if we provided care. And that's kind of what we do here. We do a quick 5-minute assessment on the patient to determine whether or not they can tolerate dental care. And if they can't, let's come up with a different plan and to make sure we can accommodate and meet their needs.
Just out of curiosity, is dentistry and especially the work that you do, is that on the curriculum at the med school at OSU or NeoMed or around the state?
Yeah, it's we have the Nisonger Center has a program for the medical students where they teach them some interviewing techniques on how to work with patients with intellectual and developmental disabilities. We have dental students rotate through here that get some exposure to this. What we find with the patient population that we see, out of a class of 120, there might be 2 or 3 that are interested in doing what we do. And then we encourage them to do general practice residencies and if possible, a IDD fellowship to take care of this at-risk population. I mean, we medically stabilize patients, patients with autism. We teach we're trying to teach we want our, in the next month, we're going to the CAS clinic, which is the autism clinic, to teach the medical providers there how to safely stabilize the patients so that way we can do blood draws. Um, I mean, blood draws is often one of the most difficult things that we do. And have we done blood draws here in the clinic? Absolutely. Have we given, I'd love where I came from before. I mean, my clinic at Arkansas Children's, we had two nurses that would go through the patients before we would see them as dental providers. And we used to give immunizations. We used to do blood draws. We used to do all that in our clinic. Here we're a little bit more isolated. There's been occasions where we've given a few immunizations but I would love for us to be totally integrated with our medical providers. I would love to have in a perfect world, I would have a center for IDD in which primary care, psychiatry, gynecology, ophthalmology, and dentistry and neurology would be all together. And that's kind of what I had where I came from. We would see our patients together. So it was pretty common to have otolaryngology in the dental clinic and dentistry and neurology. Since we worked, everything from the neck up was all together. But we see patients with traumatic brain injuries all the time, and we do try to train our students to get some exposure to this population.
Right. Debbie, you had a question?
Yeah, thank you. This is something, especially for our DD providers, we've seen a lot of concerns. Access is a major issue. I love the number that you gave, that only 11% of the dentists accept Medicaid. That is a huge issue. I know not too long ago, Medicaid did some special extra payments for people with, more challenging needs. So we're kind of hoping that maybe that additional payment rate would help. But I guess my question for you is, I know you guys do this at Nisonger Center, and I heard you say, you've got a waiting list of, 300 people. Have you worked with any of the other colleges around Ohio to see if you can help them to start similar programs so that we can get more access in different parts of the state?
I've worked with the University of Cincinnati. We talk quite a bit. One of the things that we're doing is we started a community provider certificate training program in which it's funded by the Delta Dental Foundation. And our goal is to train FQHC teams to start taking care of this population. We started it this year. We trained two teams of three, so 6 individuals every month. And it's for providers in Michigan, Indiana, Ohio, and North Carolina. We're going to have our first Ohio group coming up pretty soon. The Delta Dental Foundation wants us to train the University of Michigan faculty and the University of Indiana University faculty. They're coming next month, and to hopefully start providing these services in their clinics, because currently they're not providing the services that we provide at the Nisonger Center at Michigan or at Indiana. Our goal is to be able to train these providers and FQHCs to see some of these patients, be able to, I would love for them to learn how to suction out a trach. I mean, a lot of times the staff comes with them and they can suction, but we as healthcare providers need to know how to work with a patient with a trach. It's just basic anatomy, what you need to do, and understand how to do it safely. And I have hope that the University of Cincinnati, their program is going to take off, so increase the access for the southwest part of the state. I know I've worked with people up in Cleveland some. I don't know how far they've gotten. I mean, it's difficult to find. I mean, I've been doing this for 25 years, I mean, and it's difficult to find those individuals who have the heart and the mission to do it. A lot of the things that we're dealing with that's a problem is the student debt that our dentists are coming out with. It's not common to have six or $700,000 in student debt when you graduate from dental school. I mean, dental schools basically anywhere between $100 to $150,000 a year. And one thing that I did do is we worked with a few foundations to create a scholarship to offset. If we could find these individuals during their first 2 years of dental school, we have a scholarship now that pays all their tuition the last 2 years. And to try to decrease the amount of debt so that they can go in and take care of this population. Just because that burden of student debt is pushing more and more of our graduates into private practice and not into public health or academia. And what we do is public health, and it's often quite difficult to find and to be able to justify it as a student to do this work, knowing that you have those large student debt payments coming up. Any other questions?
What is the number as far as cardiovascular disease or other diseases? Do we have a number that may help to prove that preventative dental care from maybe youth, teenage years, et cetera, would be absolutely cost effective in the end stage diseases that are caused by poor dental hygiene?
I don't
Is there
think we
any?
have, I don't think we have any long-term studies. But what we do have is there's if a patient has significant periodontal disease, we know they're going to have heart disease. And there's a direct and there's been scientific studies saying that the bacteria that causes periodontal disease release cytotoxins which stimulate the plaque formation in arteries and veins. So I don't think there's any long-term studies, but I believe that the correlation that we have with the studies is pretty evident that periodontal disease and heart disease go hand in hand. And just like the oral bacteria is the number one, endocarditis is caused by a bacteria that's commonly found in the mouth. So we know that there's a direct correlation between bacterial endocarditis and oral health care. And that's why we give antibiotics oftentimes for patients who've had valve issues or history of bacterial endocarditis in the past.
So it just seems like the return on investment would be significant if someone would do a study that the cost savings would be significant for the general population, Medicare population. That was just a curiosity. I didn't know if numbers were out there because I've always not understood why basic dental care, preventative dental care, and also, ophthalmologic care, eyes and teeth seem to be a different part of the human body that are not covered by general insurances. Why those aren't involved. My other question, though, too, is given that we're all in this bottled water environment where we have to drink, purified water out of a bottle, no fluoride, fluoride-free toothpaste is more natural. Are we seeing anything do we get our fluoride then from cooking enough, if we're making pasta, rice, etc.? Where are we getting our fluoride to help us prevent caries?
The answer is we're starting to see more dental disease in individual. I mean, some bottled water does have fluoride in it. Others don't. We're starting to see a slight increase in dental caries in individuals that drink bottled water all the time. Just like I mean, dental caries is just your simple bacterial disease. I mean, if you need a host, you need a bacteria, and you need refined sugar. And refined sugar could be there's sucrose, fructose, or lactose. And if you are missing one of those, you're not going to get cavities. I remember one time went through a terrible fluoridation battle in Hendersonville, North Carolina, which it was the largest community in North Carolina that wasn't fluoridated, and there were 70,000 water users. And there was a nurse who worked as a missionary in Africa, was adamantly opposed to putting fluoride in the water because none of the kids in Africa had cavities. And the reason why they didn't have cavities is because they didn't have access to a lot of refined sugar. So if you have a diet that's high in carbohydrates, which tends to be lower economic groups, and you'll have higher rates of caries in that group. So, I mean, I think pretty soon it's going to be common in these communities for us to start prescribing polybiflor vitamins for our pediatric populations again. I thought we were done with that, but I guess not. I wish that I know that doesn't totally answer your question, but we are seeing an increase in, if you drink bottled water, you're seeing an increase in caries rates. And if you're not using a fluoridated toothpaste or fluoridated mouth rinse, you're seeing
Is using a fluoridated toothpaste enough?
It depends. If you have let's say, it depends on your diet, to tell you the truth. If you're drinking Cokes all the time, probably not. If you're drinking sweet tea all the time, probably not. If you're able to keep your mouth clean and you're drinking sweet tea and you're able to get rid of the bioburden, you'll be fine. But a lot of our patients don't have very good hygiene, and if they're drinking a lot of sweet tea, they are going to have cavities. So and that fluoridated water or not, but fluoridation it's been proven to be very, very effective to decrease caries rates because it increases the remineralization of the dental enamel. And we'll be seeing an increase in dental disease just because of all the communities that are becoming non-fluoridated now.
My last question is, why are dentures not fitted with some sort of device to find them when they're taken away on food trays, thrown in the trash bin? Why can't we do a Find My Denture kind of app? Is there nothing that can be embedded in them?
I think the problem is when dentures are fabricated, they are under high pressure and high heat. And I'm afraid the electronics will probably be destroyed, but I will look into that.
Sure.
Okay?
Well, no, I think it would be a great invention, but
it would be great. I mean, and thing about it is I got my hearing aids. There's a new app to find your hearing aid, and unfortunately for me, I got the hearing aids one generation too soon because my hearing aid is on the golf course someplace when I took off my shirt. And with the new apps you have for hearing aids, they will pinpoint it on the map exactly where your hearing aid is. And that would be great for dentures and other things as well.
On that note, one of our problems is that our patients start to lose weight, then the dentures don't fit, and then they start to get sores, they stop wearing them, they lose more weight. It's a vicious circle. It used to be we could replace dentures every 4 years. Is that still the protocol, or is there an as needed, or?
No, it's every 7 years.
7 years. Wow.
7 years.
Even if they've lost weight.
Even if they lost weight. You can reline dentures before then.
Okay.
Yeah, relining, that's something that can be done. And usually it will make the denture fit better. And And there's different types of relines. There's ones that are soft. There's ones that are the hard. It depends on the patient.
Okay.
In a perfect world, we would have a wise man once told me that you charge them twice for the upper one and the bottom one's free. Because the lower denture is very, very difficult it takes a lot of muscle control in order to utilize a lower denture. And that involves both the lip and the tongue. Uh, in a perfect world, we'd be putting a couple implants in to stabilize that lower denture. And patients who could tolerate it, unfortunately, Medicaid doesn't cover it, and you have to have really good hygiene. But putting implants in it increases the ability to retain the bone on the lower mandible, and also it keeps the denture stable in space. And you'll notice a significant improvement in the masticatory function of individuals who have lower implants on a denture.
Very good. Thank you so much.
You're welcome.
Mandy, did you have a question or comment?
Sorry about that. I was muted. My only thing is that we find that it's easy to find, not easy. As you said, there's not very many dentists in the state that take Medicaid, but much easier to find general care. But when it comes to those who need oral surgeries, it's almost impossible to find that. And we have seen in nursing homes where citations have risen to immediate jeopardy level because those caries have led to sepsis and systemic infection. So that's a concern, is how do we get that care for the residents that need it?
I think we're doing a disservice for our students sometimes like when I went to dental school, I took out 800 teeth. And I worked with an oral surgeon, but nowadays a lot of the students, when they come out, only do a handful of extractions, so they don't feel comfortable doing it, and so they automatically refer them to a oral surgeon for the care. And a lot of the oral surgeons, even though quite a few actually take Medicaid, a lot of them don't have hospital privileges. And some of our patients are so medically fragile that the work needs to be done in a hospital environment, and which is quite difficult, especially to find oral surgeons who are willing to go to the hospital. I mean, here at Ohio State, we have an oral surgery department at the dental school, and I know it's impossible to get in to see them. I think I was supposed to have a meeting at some point with somebody at the state about that. And I mean, we do a lot of oral surgery here at our facility. I mean, it's just because that's what we received training for when we went after dental school. But it is a problem. It is a very, very difficult problem, and unfortunately, I don't have an answer for you. I really don't. I mean, we could probably take care of some of them, but I know we're overwhelmed as well. But you have my email address. Email me if there's something that I can do to help you guys. I mean, we're here to help you who are in the state. And whatever I can do, I'll try to help you guys find somebody, or if need be, either have Dr. Tragus or I take care of it.
I appreciate that. And I don't want you to think that I was expecting an answer. That's just kind of a general issue that we're seeing throughout the state that is a concern. And, our providers are really struggling with how to meet the needs for those residents. But I definitely appreciate your answer.
Hey, what we can do is when I was at the University of New Mexico medical student at the medical school there, I used to teach all the emergency medicine residents how to do extractions. And they would take anywhere between 50 and 100 teeth out in order to be and because it was such a problem of individuals going to the emergency room for abscessed teeth that our solution was to train the emergency room residents and attendings to take out teeth. And if there's any problems, I was always their backup. So maybe I should teach you physicians how to take out teeth, so that way legally you can do it. That way, if you feel comfortable, you could help your own facility.
Teach us how, but also teach us when it's appropriate. Because we wouldn't just be pulling out teeth just because you
I
can.
know that was all part of it.
I know. Alan, you had a comment or a question? No? Oh, okay. I think you're onto something with that, putting a chip in a denture. That would be something that the general public could take advantage of, not just in long-term care. I think
I
you
mean,
use your dentures everywhere.
we do it to our dog. I mean, hey, um, I think it would be great, especially since we know dentures tend to walk off. And they can be tucked underneath napkins. They could be tucked everywhere. And I'd made a set of dentures, and the patient came in without her dentures. And I asked her where they were, and she goes, "Well, I had a sore spot, so I threw them away."
Oh, jeez.
And I go, "Janie, you know I can't make you another one, and you can't." And it happens. It happens all the time.
Yeah. By accident, or like you said, just not understanding.
You're correct.
What, just one last question. What relationships do you have with the FQHCs around the state? I know in my county, in Medina County, we have an FQHC at our health department.
So what we are doing is we have a contract with the Delta Dental Foundation to start training community providers to take care of patients with intellectual and developmental disabilities. And our goal is to train all the providers in the FQHCs so that they have the basic understanding on how to take care of some of our patients. With even the moderate ones, if we could take care of only the severe ones, since I do have hospital privileges and sometimes they do need to go to the hospital, but our goal is to be able to try to train enough providers to create a critical mass so that we have a providers spread out throughout the state that would be willing to take care of this population. And they come in there's an online component, then there's 3 days of hands-on training, and then we're working with the University of Pennsylvania to create additional webinars to help give them additional information on how to take care of patients with intellectual and developmental disabilities and also patients who are in long-term care facilities.
I may reach out to our commissioner and see if there's anything going on in that regard here in Medina County, but if not,
I can tell you it hasn't happened yet.
Okay.
Sandusky has reached out. We got Mansfield's reached out. We got Worthington. There's a facility in Worthington we're going to be training here in July. I think Sandusky and Mansfield maybe in August. I mean, our goal is to keep this contract going for 4 to 5 years to be able to train as many providers as we can. And then hopefully the providers we train can train the new providers that join them in their practices.
Thank you. Well, I'm hoping you'd be willing to come back and talk more about this issue. I think this was a great presentation and really hit home with all of us, I think.
Well, I'm always more than willing to, and you guys have any questions, just email me. I'll try to get back to you as much as I can.
Thank you.
The Nisonger clinic here, our dental clinic is part of the medical school, by the way. And and I think because of that, we're a little bit more in tune to what goes on in healthcare. I work with psychiatrists and psychologists on a daily basis. And my whole career has been interdisciplinary, and that's working with individuals like yourselves makes me feel at home.
Well, I think the Neomed is going to start it. They think they're taking their first class of dental students in September. I think they're going to start at Neomed. Is that correct?
Yeah, that would be great. And if they want a clinic that takes care of patients with long-term patients with intellectual and developmental disabilities or in long-term care facilities, I would be more than willing to help them get started.
Yeah, and they do a lot of stuff. They're innovative with getting students integrated into the clinical realm early. So I think they're very interested in being, on the cutting edge of new ideas and new practices. So I'm on the admissions committee. I don't know what kind of pull that has, but I'll see if I can talk to someone up there that might reach out to you. I don't know. We'll try.
Yeah, that would be great. And just like we're trying to help the group in Cincinnati, we got to get them up here to be trained. We have a new D9997 code, which is a code that is case management for patients with intellectual and special healthcare needs. We're trying to, we're working to set the guidelines on how to use that code. Because I don't want, the thing I'm always worried about is fraud. I have a master's in health administration, and my project my master's project was creating the fraud detection system for the state of Arkansas, and it was pretty remarkable, some of the stuff that we wanted to see and some of the stuff we saw, and how I want to do whatever I can to make sure that we're good stewards of the state's money and not and making sure that our individuals are getting the services that they need and the providers are being compensated correctly for it.
Okay, thank you. All right, we're a little over time, but this was a great talk. And again, Dr. Beetstra, thanks so much for being here this morning. This was terrific.
Thank you all, and you guys got my email.
Yep, we do. We'll be in touch.
I got a clinic full of patients, so I got to get to work.
Okay, have a great day. Thanks again.
Thank you. Bye.
See everybody next week.